Dr. Dara Jamieson is here. She is a clinical associate professor of neurology at New York Presbyterian Hospital at the Weill Cornell Medical Center. She is a specialist in both stroke and headache medicine. Her training was at the University of Pennsylvania in these areas and has a particular focus on stroke in women. Today she is going to be talking about the interesting relationship between patent foramen ovale and migraine headaches. Thank you, Dr. Jamieson.
Hello, I'm Dara Jamieson from New York Presbyterian Hospital in New York City. Let's start off talking about migraine and patent foramen ovale with a case report. Here's a young woman. She's 30 years old. She awoke noting left-sided weakness and a headache. She had a history of migraine with visual aura since she was 18 years old, with a family history of migraines. She had a mother with migraines that improved after menopause. She took occasional over-the-counter pain medications for headache. Her only other medications were oral contraceptives. She didn't smoke, drink, or use illicit drugs, and her review of symptoms was only positive for headaches. On examination, this woman was alert, mildly anxious, but with fluent speech with normal content. On cranial nerve, she had mildly decreased left nasolabial fold and some mild arm weakness at 4/5 in the upper and lower extremities. On sensory examination, she had decreased sensation to pinprick and light touch on her left base arm and leg, and she walked with a hemiparetic gait without assistance. Her deep tendon reflexes were mildly increased on the left side. On the next slide, we'll look at the imaging studies of this woman, and you can see that she has an area in the right parietal lobe of restricted diffusion on MRI, and on MRA, she has an occluded right middle cerebral artery branch. So here's a woman with a right parietal infarct at age 30, not with a lot of traditional vascular risk factors, but she may have some vascular risk factors that we can discern on evaluation. Well, she had an evaluation that showed on transthoracic echocardiogram a large PFO with a small atrial septal aneurysm. Routine blood work was normal, including lipid panel and inflammatory markers, and she had a hypercoagulable evaluation looking for thrombophilias, and she was not found to have any hematologic abnormality. So, 30-year-old woman, PFO, history of oral contraceptives, right parietal stroke. How would you treat this woman? Would you tell her to stop her oral contraceptives totally? Would you tell her to take aspirin, such as in A? Would you tell her to take warfarin, such as in B? Would you suggest that she switch to a progestin-only contraceptive and take aspirin for secondary stroke prevention? Or should she take, again, warfarin for secondary stroke prevention with a history of progestin-only contraceptive use? Would you instruct her to stop contraceptives and have her PFO closed? Thinking about what's the correct answer with this woman, you could actually make a case for any of these answers as far as treating this woman. Certainly in an individual who has had an acute ischemic stroke, you want to stop oral contraceptives. The concern may be oral contraceptives that are estrogen-based, and given that the risk of having a cerebrovascular complication of pregnancy is relatively high as compared to the risk of having a cerebrovascular complication of oral contraceptives, you might talk to her about the consideration of a progestin-only contraceptive as opposed to a combined oral contraceptive. Although, if she could get along with another contraceptive medication, then maybe it would be good not to be on any contraceptives at all. As a side note, I think it's an issue in this woman that at age 30 with migraine with aura, she was taking oral contraceptives that included estrogen because, as you'll see later in this presentation, this may be a reason that her acute ischemic stroke was more likely to occur. A, B, C, and D talk about warfarin versus aspirin, and as we'll see, either one may be an appropriate therapy, or maybe you're going to tell her to stop all oral contraceptives and have her PFO closed. So there really isn't any correct answer to this particular question. I think it's worthwhile if we talk about migraine without aura and migraine with aura, because it's very important to understand the distinction between these two concepts. First off, migraine is a very common disorder. About 30 million Americans have chronic disabling migraines. About 1 in 4 households has a migraine sufferer. So migraine is a disorder that you are likely to experience in your patients, in your family, or even yourself. The International Classification of Headache Disorders in 2013 published criteria for migraine with aura that you can see here. Headaches that have at least 2 of the following categories: unilateral location, pulsing quality, moderate or severe pain intensity, aggravation by or causing avoidance of routine physical activity. And most patients with some of their headaches have nausea and vomiting, photo or phonophobia. If you look at the next slide, you can see migraine without aura, which has the same criteria as migraine with aura, but you add to it fully reversible aura symptoms. These can be visual, sensory, speech or language, motor, brainstem, retinal. These aura symptoms last about 50 to 60 minutes and are accompanied sometimes with a headache afterwards, and sometimes you can have the migraine aura without any headache whatsoever. So you would have a migraine equivalent, a migraine aura without headache. These descriptions from the International Classification of Headache Disorders are good for clinical trials, but they really are too restrictive to use in clinical practice, in that patients who have migraines may have bilateral pain. They may have stabbing pain. Their pain doesn't always have to be accompanied by nausea and vomiting. Some headaches may not have sensitivity to light, sound, and smell. There's a wide variety of symptoms that patients who have migraine, both with and without aura, experience. The next slide shows some migraine auras, and you can see the distortion in vision that occurs in someone who has migraine auras. You can see that in the top man with visual aura and sensory slide, that the aura doesn't have to be just visual. It can be sensory, it can be motor. There's some thought that Vincent van Gogh's picture Starry Night actually was a representation of his migraine aura. You can see the swirling pattern that is commonly seen with a scintillating scotoma. You can see the stars, which look like what we call photopsias, or flash bulb, paparazzi bulbs that go off in the vision of somebody who's having a migraine with aura. However, people who have migraines are going to have many different aspects of their migraine, both with symptoms that start prior to their migraine, what we call premonitory symptoms. They may have fatigue, they may feel irritable, they may feel emotional, and then when the aura occurs, it usually, not always, but usually occurs prior to the headache, classically about 20 minutes, although it can last, as you saw in the prior slide, from 5 to 60 minutes. And then there is a period after the aura resolves where nothing much is going on, and then there is a gradual onset of a dull headache, which may have some autonomic symptoms along with it, as you can see, nasal congestion, sometimes tearing, and then the headache increases in severity, maybe bilateral, maybe unilateral, maybe throbbing, may have the sensitivities, and then when the headache is over, the patient usually feels wiped, tired, with cognitive changes, maybe emotional changes, and this entire process may take, in some patients, hours to days. The next slide makes an important point that migraine produces changes in the brain. People who have migraine headaches generally have smaller brain volume than non-migraineurs. There may be earlier atrophy seen on MRI, but what is most characteristically seen on MRI are white matter lesions. And these white matter lesions can be deep within the white matter or they can be periventricular. Sometimes we see what we call subclinical infarcts in the cerebellum or pons, meaning that you see white matter infarcts in these lesions. However, I would caution you about using the word infarct, although these are sometimes called subclinical infarcts, because as you would well imagine, we don't have tissue on these patients with these lesions that are perfectly normal and not of any concern. Therefore, we're not exactly sure if these are infarcts or they're gliotic changes or what exactly is causing these white matter lesions. It seems that women migraineurs, and remember, of course, that women are significantly more likely to have migraine than are men, are at risk of having deep white matter lesions. And the more headache attacks they have, the more likely they are to have these deep white matter lesions. It's a little bit controversial whether it's more common in migraine with or without aura, but probably is not related to having an aura, and that becomes important when we talk about some aspects of migraine and PFO. There's no increased risk for periventricular white matter lesions in people with migraine with aura as compared to the general public, although they're often frequently seen. And what are called subclinical cerebellar infarcts are seen more frequently in people with increased migraine frequency and may be associated with migraine with aura. On the next slide, you'll see one of my patients who's a 53-year-old woman with migraine with aura, and you can see that she has multiple white matter lesions, both in the deep white matter, the periventricular region, and in the pons. This is all the same patient with multiple lesions, and these are her lesions that are related to her migraine headaches. You can see here a very small lesion in the cerebellum as well as her pontine lesion. Now we're going to move on in the next slide to migraine-associated conditions. Migraine is not just a headache. There are other disorders that are associated with migraine. Some of them are neurologic disorders. There's a greater incidence of depression and anxiety in individuals with migraine. There are movement disorders that are seen more frequently in people with migraine. There's a crosstalk between migraine and epilepsy. But what we're going to be talking about today is the overlap between cardiac conditions and migraine, and specifically patent foramen ovale. It's worth remembering that migraine and mitral valve prolapse occur more frequently, and at one time mitral valve prolapse was thought to be a significant vascular risk factor. We know now that it is not, and it would be interesting to see if this history of the association between mitral valve prolapse and migraine is played out with the same eventual lack of correlation with PFO and migraine. You can also see that migraine is associated with ischemic stroke and myocardial infarction. And on the next slide, you can see listed some of the vascular disease and migraine overlap. Cerebrovascular disease, and specifically ischemic stroke, is more common in individuals who have migraine with aura. And should you add cigarettes and oral contraceptives to that mix, the risk continues to increase. That gets back to that 30-year-old woman that I was discussing in the beginning who was put on oral contraceptives with frequent migraine with aura, perhaps not the best thing to have done. Arterial dissection is more common in individuals with migraine, as are delayed ischemic neurologic deficits after subarachnoid hemorrhage. Interestingly, individuals who have migraine are more likely to have hypertension-related complications of pregnancy, and it becomes very important to watch the blood pressure of these women, especially after they've delivered, because their rate of eclampsia and preeclampsia may be higher than in the non-migraine population. And then cardiovascular disease, as I said, mitral valve prolapse, myocardial infarction, and patent foramen ovale are seen more commonly in patients who have migraine. Two studies looked at large populations of individuals and followed them for a long time, looking at various health conditions, one being the Physician's Health Study with men mean age in their 50s from 1982 to 2005, another one being the Women's Health Study, again, mean age in the 50s, 1993 to 2004. And as part of the follow-up in these studies, they asked about migraine headaches and followed these individuals looking at vascular outcomes. In the Physician's Health Study, they didn't differentiate between migraine with aura and migraine without aura, but found that the increased ischemic risk in individuals who had migraine was increased MI, increased ischemic stroke, no increase in angina or revascularization in the men. In the women, where they looked in the Women's Health Study at individuals who had migraine with aura as opposed to migraine without aura, they found that migraine with aura was associated with increased ischemic stroke risk, increased MI risk, and increased risk of cardiac revascularization and angina. This is very interesting, and it brings to question, why is there this correlation? Well, the next slide shows that individuals who have migraine, especially migraine with aura, are at increased risk of having traditional vascular risk factors. The genetic epidemiology of migraine population-based study looked at individuals who were current migraineurs as well as controls and found that smoking correlated with migraine, having disorders of cholesterol correlated with migraine with aura, as did elevated blood pressure, as did early onset heart disease or stroke. So they found that migraineurs, especially those who had migraine with aura, had a higher cardiovascular risk profile than individuals without migraine. Various explanations on the next slide have been put forward to try to figure out why is there this correlation between stroke and migraine, and more clearly the correlation between stroke and migraine with aura. Individuals who have migraine appear to have abnormal platelet function, they have increased platelet activation during a migraine attack, and they have increased stickiness of platelets between migraine attacks. There seems to be increased cerebral vasoreactivity associated with migraine. There may be alterations in arterial function. There may be a correlation with cardiac dysrhythmias, with hypercoagulability in patients who have migraine. How do you explain the increased correlation with migraine with aura? Does that mean that migraine with aura is an ischemic phenomenon? Is there correlation with right to left shunting? Does this mean we should be treating patients who have PFOs differently? And what about the somewhat, in my mind, suspect, but the noted migraine frequency decrease after a patient has an acute ischemic stroke? On the next slide, you can see a normal atrial septum, and we're going to be talking about abnormal atrial septums, PFOs. The next slide shows a PFO. Here you can see that there's an opening where fibrous adhesions fail to seal the atrial septum after birth. This produces a potential shunt between the right and left atria of the heart. You can see in the picture an agitated saline or a bubble study demonstrating right to left shunting through the PFO. It's difficult to determine what the true prevalence of PFO is in the population because, as you could imagine, there may be different prevalences depending on how you go looking for a PFO. In autopsy studies, about 17 to 27% of people have this opening that never sealed after birth. On echocardiogram studies, 3 to 18% seem to have it, realizing, however, that if you don't do an echocardiogram with agitated saline, bubbles that can cross one way or the other, you're much less likely to pick up a PFO, specifically a small PFO. Also, if you don't ask the patient to do maneuvers during the study, such as bear down, Valsalva, cough, you're less likely to pick up a PFO on an echocardiogram study. Now, PFOs are often associated, about 70% of the time, with atrial septal aneurysms. On the next slide, you can see pictures of different types of atrial septal aneurysms. An atrial septal aneurysm is present when there is redundant tissue in the region of the fossa ovalis and you have too much septal wall motion. And there's a definition of how much septal wall motion you would have during respiration. There is some thought that perhaps an atrial septal aneurysm confers more vascular risk than a PFO alone, but as you saw in the previous slide, about 70% of PFOs have an atrial septal aneurysm with them as well. Now let's get into the topic of PFOs and migraine, and I'm going to ask you two questions. Question number one, what is the prevalence of PFO in individuals with migraine without aura? And you can see you've got various ranges from a very low prevalence to a 70 to 80% prevalence. Before we answer this question, let's go on to the next question, which is, what is the prevalence of PFO in individuals with migraine with aura? And again, you have the same choices. All right. Let's go backwards now to the first question about the prevalence of PFO in individuals with migraine without aura. The answer to this question is whatever the prevalence of PFO would be in the general population. In other words, the population seems to have a PFO prevalence of approximately 20 to 30%, so the answer is C. On the next slide, however, looking at the prevalence of PFO in individuals with migraine with aura, you are more likely than not, if you have migraine with aura, to have a PFO. So the prevalence of PFO in migraine with aura is 40%. So the answer to that question is D. Here on the next slide, you can see the answers. Migraine and PFO are both common problems in the population. Migraine prevalence is about 15%, although probably we are still only diagnosing the tip of the iceberg in individuals with migraine. It's probably higher than 15%, but let's say 15%. Approximately 20% of women, approximately 10% of men have migraine, and about 4% of the population have migraine with aura, realizing that not every migraine headache has to have an aura with it. So people who have migraine with aura may have headaches where they have no visual, sensory, or motor abnormalities, but then they have some headaches that have visual, sensory, motor, speech abnormalities associated with them. And then the PFO prevalence is about 20 to 30% by TCD with agitated saline, which is a good way of picking up a PFO, or transthoracic echocardiogram. And those individuals who have PFO have a much higher likelihood of having a migraine with aura disorder. Migraine without aura, PFO prevalence about 20 to 30%, back to whatever the normal population is, but individuals who have migraine with aura appear to have about 40 to 60% prevalence of PFO, and they tend to have larger PFOs, more right-to-left shunting at rest. What about chronic migraine? The next slide shows a study that looked at individuals with chronic migraine. Chronic migraine is defined as headaches lasting greater than 4 hours for 15 out of 30 days for more than 3 months. And this study found that 66% of patients had a right-to-left shunt if they had chronic migraine. So this is clearly a much greater prevalence in the population of chronic migraine patients than it is the general population. Note in this study, they looked at TCD with contrast and Valsalva as a way of picking up the PFO. Children, the next slide shows patent foramen ovale in children with migraine headaches. And in this study, they looked at 109 children with migraine with and without aura, remembering that children as young as 5 years old which is when migraine with aura often starts in boys, can have a migraine disorder and can have migraine with aura. They found that in these children from 6 to 18 years, they had overall a PFO prevalence of 35%, but when they broke that down, the migraine without aura prevalence of PFO was 27%, close to the general population, but there was a significant increase in migraine with aura at 50% as compared to the general population. So even children who have migraine with aura have a greater incidence of finding a PFO. The next slide looks at a study from the Northern Manhattan study on patients who were picked up as stroke-free individuals looking at stroke incidence, risk factors, and outcomes in a multi-ethnic Northern Manhattan population. In this study, they did transesophageal echocardiogram with contrast in about 1,000 patients and looked at self-reported migraine prevalence. They did not find an increased incidence of PFO in individuals with migraine. But I personally have criticisms of this study in that let's look at the age of the people in these studies. 69 plus or minus 10 years. We know that migraine starts in childhood. We know that it increases in adolescence and young adulthood. And in almost all, not all, but almost all patients, after menopause, migraines significantly improve to disappear. So in individuals in their 50s and beyond, you really wouldn't expect them to have symptomatic migraine, although they might have had migraine in the past. So this is clearly not the demographic in which you would expect to be looking for migraine. Also, the diagnosis of migraine was self-reported, and we know very clearly that patients are not particularly good at identifying their headache type, oftentimes saying that they have sinus headache or they have tension-type headache and not picking up they have migraine. And then I'm also going to say that perhaps the transthoracic echocardiogram with contrast might not have been as good as TCD in trying to pick up PFO in these patients. So I don't see the NOMAS study as indicating that there is no correlation between PFO and migraine with aura. One question that has come up on the next slide in the SAM study, Shunt-Associated Migraine Study, is there a difference in the type of migraine, in the presentation of migraine in individuals who have a right to left shunt versus those who don't have a right to left shunt? And this was a study in which they looked at patients who had migraine with aura. So these were not migraine patients who were a mixed bag. These were migraine with aura patients, found that they had a shunt in approximately half of these patients, shunt-associated migraine in about 42%, and they looked to see if there was any difference associated with that shunt. And they found that these patients were younger, had a family history of migraine, had more sensory complaints, and seemed to have a lesser prevalence of other associated cardiac abnormalities. The thing that I find particularly interesting in the SAM study is that they didn't find that those white matter lesions, remember we saw the patient of mine who had multiple white matter lesions, was necessarily associated with the presence of a shunt. So although those white matter lesions are called sometimes infarcts, they don't seem to be associated with the presence of a PFO. Just because you have white matter lesions and migraine with aura doesn't mean that you have a patent foramen ovale. And when they looked at the type of migraine aura that these individuals had, there was no correlation with the localization of the white matter lesions. So you can't say, based on the SAM study, that patients who have sensory auras are having little infarcts in the sensory cortex showing up as white matter lesions on MRI. There just wasn't any correlation. Next slide talks about migraine with aura and PFO pathophysiology. Why is there a correlation? Well, maybe there's a correlation, but it's a non-causal correlation. Maybe migraine with aura and PFO happen to be genetically co-localized. Maybe there's an ontogenic hypothesis explanation such that there's common embryologic origin of the endocardium, vascular endothelium, and platelets, and there's a developmental abnormality that seems to cause both PFO and susceptibility to migraine with aura. Maybe there is a causal association with some type of endothelial dysfunction. One thought has been that there's a focal ischemia hypothesis where because there's a PFO, substances are coming through the right to left shunt unfiltered by the pulmonary circulation, causing ischemic changes in the brain that cause the aura. Whether this involves platelet activation or aggregation or other methods is unknown. I personally think the SAM study results that show no correlation between PFO and white matter lesions and no correlation between the type of aura and the localization of white matter lesions goes against the chemical shunt focal hypothesis theory. Very briefly, the issue of PFO and cryptogenic stroke. This has been covered before, and we know now based on clinical trials there are problematic aspects to this correlation, but there have been meta-analyses looking at patients with cryptogenic stroke, found that a high percentage of strokes in young people are of unknown origin, and that PFO may be detected in these individuals. PFO occurs, as we said, in normal individuals, but may be associated with stroke in people who are younger with large PFOs and atrial septal aneurysms, with a blood clot, paradoxically, as you see in the figure, going through the opening. Because of this concern about a correlation, there have been PFO closure trials, and you can see on the next slide various endovascular closure devices that have been used. On the next slide, you can see 5 different theories of the best description of the results of 3 recent PFO stroke and closure trials. A, PFO closure has been shown to be superior to medical therapy in decreasing recurrent strokes in the majority of patients. B, warfarin is superior to antiplatelet therapy in decreasing risk of recurrent stroke. C, device closure can be accomplished without any significant increase in adverse events. D, atrial fibrillation is rarely noted in the population followed in the PFO and stroke trials. And E, benefit for device closure over medical therapy is unproven. I'm going to go with E on this one, and we really aren't going to talk about this much, but I think this comes into play thinking about migraine and PFO. If you look at the next slide, this is an overview of the 3 trials, Closure 1, Respect, and PC trial. And the bottom line is that none of the trials in the primary intent to treat analysis showed any benefit for device closure with patients who had a stroke, PFO, and the idea was to try to prevent recurrent stroke. What I also found interesting in these studies is that they didn't seem to indicate any particular beneficial medical treatment between anticoagulation and aspirin. Specifically in the Closure 1 trial, there was no difference in outcome events between warfarin anticoagulation and aspirin use. The next slide talks about PFO closure and the effect on migraine frequency and severity. In 2000, there was an incidental observation made that PFO closure was associated with decreased headaches. And pooled analysis of observational studies looked at this question, and there was some indication that 83% of individuals who had migraine headaches had either complete cessation of their headaches or a clinically significant reduction in headaches resulting from closure of their PFOs. However, there's only one completed randomized controlled trial of PFO closure in migraine, and that's the MIST trial, and that trial did not show clinical benefit with closure. The next trial shows the study design of MIST. This took patients who were aged 18 to 60 who had a history of migraine with aura, and they had to have migraine with aura at least 5 times a month, and they had to have failed prophylactic medication treatment with 2 classes of medication. So these were individuals who, as you can see, were predominantly female, had a mean age of 44 years, and a mean follow-up of 6 months. They had transesophageal echocardiograms to see if they had PFOs, and of those individuals who had PFOs, 74 underwent closure, and 73 were put in a sham procedure control group where they had a groin incision under general anesthesia but did not have any instrumentation or a closure of their PFO. Everybody was put on aspirin and clopidogrel, and the endpoint was absence of migraine during a 3-month follow-up period after clopidogrel discontinuation. The results had negative both primary and secondary outcome results, but it's worth looking first at some of the screening aspects of it. As I said, this is the first and only completed prospective randomized placebo or sham-controlled trial with NMT manufacturer of the StarFlex closure system. They looked at the migraine with aura population, and remember these were individuals who were in their 40s, and found that 60% had a right to left shunt, thinking back in the NOMAS population, which were individuals in their 60s to 70s who did not have that increased prevalence. And they found that no shunt was seen in about 40% of individuals, and a large shunt was seen in about 38% of individuals. As I said, there was no significance, as seen in the next slide, between individuals who had PFO closures and individuals who had sham closure in the complete cessation of migraines, both with that primary endpoint and in secondary endpoints involving incidence, severity, frequency, characteristics, and quality of life. So the MIST trial did not show evidence of efficacy for PFO closure in the treatment of migraine with aura. What are some concerns about this? Well, on the next slide you can see limitations and concerns for the MIST trial. I think it was very unrealistic to think that with a 6-month follow-up and 3 months of monitoring after stopping clopidogrel, you're going to have complete cessation of headaches in individuals who have frequent migraines. It just doesn't make any sense that any treatment is going to be that good. As I said, the follow-up period was very short, and migraine is an episodic disorder where people may have frequent migraines for a matter of a few months and then may go for months with no migraines and then have other months where it comes back frequently. And as I tell patients, we can try to figure this out, but this may just be chaos in the universe. There's no reason to be able to interpret why some months are bad and some months are good. There was a variable medical comparator arm. Some people are responsive to some therapy, others to other therapies. These women some of them were perimenopausal when there is worsening of migraine frequency and severity before improvement of migraine frequency and severity after menopause. There was a fairly large number of significant adverse events in patients in the implant group. This study had some controversy about whether the interpretation of closure was accurate, and in fact there was thought that perhaps there should have been an independent review board for the transesophageal echocardiograms. I also was disturbed that 2 outliers who had high-frequency headaches were removed from the data analysis because they just had too many headaches. That's what happens with people with headaches. They often have lots of headaches, and I wasn't sure why two individuals who replicate what is usual clinical practice would be removed from the data analysis. After the negative effects of Closure 1, the manufacturer of the device actually filed for bankruptcy. There is a second trial, the PRIMA Trial, that looks at a different device. However, in this case, there were no sham controls. And so patients knew that they were closed, didn't know, or knew that they weren't closed. These were individuals who were randomized to device closure. They found that at 1 year, there was no significant decrease in the number of headache days from baseline. There was significance in the secondary endpoint in decrease in migraine with aura days from baseline. However, as I said before, patients who have migraine with aura probably, for the most part, have more headache days where they don't have aura than headache days where they do have aura. So just because you have the label of migraine with aura doesn't mean that every headache day is associated with an aura. So I think it was more reasonable to look at reduction in headache days in the aggregate as opposed to reduction in migraine with aura days. And there was no difference in patient satisfaction or quality of life with the closure. There is an ongoing PFO closure trial, the Premium Trial. 2 other trials, MIST-2 and ESCAPE, were closed because of difficulty recruiting patients. So issues of PFO closure and migraine with aura. Just to summarize, migraine with aura is associated with an increased prevalence of PFO, but migraine without aura is not associated with that increased prevalence. We don't know why this correlation exists, and it's not necessarily one causing the other. The sole completed sham-controlled study did not show benefit with closure. Migraine attacks are episodic over years and can decrease at various times during a woman's lifespan. For instance, they tend to be worse in adolescence, better in the 30s and 40s, worse around perimenopause, better after menopause. We have new treatments and strategies now, such as Botox injections for chronic migraine, which will continue to dilute any supposed benefit for device closure. I don't think that it is justified to take an expensive and invasive procedure and perform it just for a mild reduction in headache days, especially when other treatments can be used. So I believe that PFO closure and migraine with aura has not been shown to be of clinical benefit and should not be used for the treatment of migraine headaches. Well, let's get back to the 30-year-old woman with migraine with aura, PFO, and stroke. What happened to her? Her PFO was closed percutaneously with an Onplotzer closure device. At follow-up TEE, the device was not found, and so a diagnostic procedure was performed. On the next slide, take a look at this picture. What do these images show? They show a PFO closure device, and you can see here a PFO closure device. This woman had migration of her septal occluder to the upper abdominal aorta, as seen on CT of the abdomen and pelvis. Endovascular retrieval could not be performed because the device was embedded in the aortic wall, and she underwent a surgical procedure with a Dacron patch repair of the upper abdominal aorta in order to retrieve the device. And you can see here on the next slide the Dacron patch. The 30-year-old woman with migraine, PFO, and stroke underwent surgical closure of her PFO, but still had residual passage of bubbles after open surgical closure. Her neurologic recovery was excellent. She discontinued birth control pills. She takes daily aspirin. Unfortunately, she developed a post-infarct seizure disorder treated with medication, and her headaches continued. So in conclusion, I gave you what I think is a reasonable overview of a subject that has been controversial in the past, but with recent clinical trials I think is becoming less controversial. The issue of the correlation between PFO and migraine with aura and whether or not device closure should be used to treat migraine in these patients, not to treat stroke, but to treat migraine. And my belief is that there is no role for PFO closure in the treatment of migraine in order to decrease the frequency and severity of severe headaches in the migraine with aura population. Thank you very much.
Thank you, Dr. Jamieson, for this thoughtful and thorough review. We look forward to the results of ongoing trials that continue to address this potentially fascinating relationship. Please join us in the future for more of these types of interesting talks. Thank you very much.